This is Dr. Carol Heinrich, and today we're going to be going over urinary function and age-related changes of older adults as part of Module 5. First, we're going to talk about bladder changes in older adults, and these are normally expected changes. So bladder capacity has a gradual decrease as someone ages, and again, it's been shown that more urine is produced at night, so you may have someone waking up during the night to void, and again, that is not disease related, but it's expected practice. Especially, a lot of it will depend on the amount of fluids that someone takes in at bedtime. Again, for women, as they progress through menopause, estrogen levels are dropping, so the tissues become thin and very friable and very easy to injure from any type of irritation. And again, the pelvic floor and muscle tone and function is a little bit lower than it was before. So again, we're going to be leaning in to what we'll be talking about incontinence in a few minutes. But just remember, even though the estrogen levels have been declining and these tissue changes take place, does not equate it to incontinence. Again, for men, prostatic hypertrophy, the prostate gland increases, and again, it's the risk. It's not again expected pattern of aging, but it does happen, and the prevalence is increasing as someone ages. And again, here is a clear myth that we have to get straight out right now. It's incontinence is normal and not worth reporting to healthcare providers. That is a myth. That is not true. Incontinence is not normal. And again, a lot of older adults think, oh, I'm just getting old, this is what happens. And they don't report it to the healthcare provider. And again, treatment doesn't take place. Incontinence is not normal. All right, now we're going to be talking about some common problems and conditions, and one is acute incontinence. And again, it's just what it says. Person doesn't have control over urination. It is very sudden, and again, usually it's when someone is hospitalized and has something to do with medical or surgical conditions, but it usually resolves itself when the cause is corrected. Again, with hospitalization, upon discharge, it resolves. Again, often medications, if it's a new medication that someone is on, and again, it should always look at the side effects and see how it affects the elderly population. Chronic incontinence is much more common and is something that we see every day in the older adult population. Again, like on that previous slide, we talked about a lot of the older adults think that incontinence is normal, but it definitely is not, and it does require treatment for overall quality of life. This list just gives you an example of the various types of incontinence. Your book clearly provides definitions and examples of these. Nursing management, again, it's a in-depth history, functional assessment, look at the environment if someone is in the community-based setting, look for safety needs about access to the bathroom and throw rugs and steps. And again, a psychosocial assessment, because again, think of the feelings someone is experiencing if they do have stress incontinence in public places especially. Physical exam, looking for friability of the tissue in a female to see if there is any skin tears, skin damage, irritation. Again, take an evaluation of their bladder habits. Do they routinely go every so many hours, or do they just wait till they really feel they have to go? Then they have to hurry and try to get to the urine to the bathroom on time. Diagnosis, it diagnoses those types of incontinence. Again, behavioral therapy is a common intervention for patients with incontinence. It can be done in acute care settings, long-term care settings, as well as in community-based settings. For people who are cognition is intact, you can do bladder retraining. By every so many hours, have them void and empty their bladder. And next 3 hours, have them void and empty their bladder. Then there's pelvic floor muscle exercises. Kegel exercises will help strengthen the muscles that control the voiding sphincters. So again, this person has to have cognition and be able to understand your directions and instructions, and then again be able to demonstrate and understand how this is done. For patients older adults that are cognitively impaired, again, you would have scheduled toileting again. Try to create habits. You have to make sure that they have adequate intake of fluids. Again, we know that the more a person takes in fluids, the more the person will have to void. So you have to make sure the person takes adequate fluids to maintain hydration balance. Fluid intake could be restricted at bedtime and during the evening, but again, if that does get implemented, make sure that the fluid intake during the daytime hours is adequate for a 24-hour period. Again, caffeine irritates the bladder, so again, you may want to restrict caffeine intake or take it out of the diet altogether to see how it goes. And maybe someone has 1 cup of coffee rather than 3 or 4, and it may help the incontinence issue. Again, if someone is incontinent in acute care, it doesn't matter what type of setting they are in, and they're using those blue Chucks pads or white incontinence pads, you have to make sure that they're changed frequently and have extra good skin care, because again, we know that urine and incontinence is very irritating to the skin and can cause skin breakdown and irritation. We know that the cost of those pads is expensive, so some providers or caregivers may not really change those pads as often as they need to be, but again, you have to make sure that's a point of education. If someone is continuing with incontinent problems, a referral to a urologist may be warranted. For your evaluation, you want to see how the patient feels. Again, if they had common stress incontinence or incontinence issues, again, they should express satisfaction that that problem has been addressed. Okay, now we're going to be talking about the kidneys, renal disease. As someone ages, the renal mass decreases. So that means the actual size of the kidney is gradually getting smaller. The glomeruli, which is the filtration of the urine that takes place in the kidneys, there's thousands of glomeruli in each kidney. So again, it's gradually cutting down on the size. And it may eventually affect the glomerular filtration rate. But again, it's the filtration rate stays stable until about 35. Then it decreases from 8 to 10 milliliters a minute per decade. So again, kidney output, urine output will be gradually decreasing, but again, it's not, the decrease is not drastic enough to cause kidney disease. So again, if there is changes in the creatinine and the BUN, it is not a normal sign of aging, but again, definitely needs to be assessed, because again, medications and older adults are known, we've talked about it before, can be on multiple medications, and again, they have to be metabolized through the liver, excreted through the kidney. So again, that dose may be adjusted, may be smaller for older adults. So keep that in mind. Again, when you're caring for older adults, check out the GFR, check out their kidney performance, and see if the medications need adjustment. Some of the more dangerous medications for older adults with kidney problems have checked serum levels to make sure they're within that therapeutic range. Okay, it can be acute kidney disease or chronic kidney disease. And again, acute is the same type of kidney disease as any other age group population. It could be caused by hypovolemic, low blood volume, and going into acute tubular necrosis as a result of trauma or surgery, dehydration. Chronic renal failure is caused by the same causes of any other age population also. And it could be, as I said, added to it is that the decrease in the glomerular filtration rate. So again, in your management of someone with kidney disease, again, a history, physical exam, again, look to see what medications they are on or how many over-the-counter meds they're taking, because even Tylenol or the NSAIDs can cause insult to the kidneys. Intervention, again, fluid and electrolyte balance is key, so it's going to be daily weights, strict intake and output, monitoring potassium levels, because as we know in kidney disease, potassium levels rise. Again, you're going to be checking out all those electrolytes, the sodium, the potassium, the calcium, chlorides. Again, you're going to be looking for nephrotic symptoms. Again, look at the color, the clarity of the urine that is being produced. Right. Again, diet management, again, maybe restricted sodium, restricted potassium. This is not any different than any other age population. So again, the management of a patient with kidney disease is going to be the same as a middle-aged adult or a young adult. All right, they may have fatigue because remember your kidneys produce erythropoietin, again, which is needed for red blood cells, which adds to the oxygenation of your tissue, so someone may be tired and having low energy. So the evaluation, you're going to be make sure you monitor fluid output, all right, urine output, fluid intake, BUN, creatinine, as well as hematocrit. The treatment could be dialysis. Again, it could be, if necessary, it could be peritoneal dialysis or hemodialysis, depending. And again, it's not any different than if it was a middle-aged or young adult. The only thing is, if someone is going home with peritoneal dialysis, you need to have someone who is cognitively intact to manage the procedures. The next one we're going to talk about is a urinary tract infection. This is much more common than kidney disease. Again, bacteria and UTIs in the urine is very common and happens often in especially women living in long-term care facilities. E. coli is the most common bacteria that causes UTIs, and in women, anatomically, the GI tract and the rectum is close to the urinary meatus. So again, that is how urinary tract infections are usually acquired in women. The symptoms are down there. Patients present with the dysuria, urgency, frequency, hematuria. They may have chills and they may have a fever. Remember, if in previous modules we talked about that older adults may not spike a fever. So again, keep that in mind, that a person could still have an infection, a urinary tract infection in this case, may not have a fever. They may have chills, flank tenderness, and confusion. The geriatric syndrome of a urinary tract infection, along with confusion, often occurs with older adults. Again, one of the first signs of a urinary tract infection may not be the flank pain, the blood in their urine, or a fever. It may be confusion. So again, keep that in mind when patients come into either clinics, physicians' offices, or even into the ED in acute care settings. A patient may come in with confusion. Person would be afebrile, but again, when you look at the urine and do cultures, it comes out that there's bacteria in the urine. Again, it would be a good management practice for, again, assessment. Again, mental status exam is always indicated. Again, you're going to be managing it. It's going to be good hygiene in the perineal area, especially for females. A lot of fluid intake. Take the medication as prescribed or administer it as prescribed. And again, you're going to be looking for signs of recurrent